a very strong day. So I think you are quite tired. And that's the reason why I decided to challenge your minds at the end of these presentations. So because you can approach this title, Evidence and Physiology, by simply demonstrating some data, or you can ask, what could evidence or physiology really learn us? So let's start to rethink the physiological-based approach. So the basic consideration, physiology taught us how things should be. So the next thing is, if you accept that this is the truth, then the conceptual consequence of how things should be is settings that lead finally to physiological normal values. So, but then we enter in the field of pathophysiology. So how can things be? So, and then we have to change our minds and to say, well, settings have to lead to acceptable values. And I will talk later on what acceptable values might be. And then if you mix both of them, physiology and pathophysiology, how should things be under pathophysiologic conditions? And the consequence of it, which anomaly or variation do we have to accept to get the whole organism back to the best level of physiology or normality? So that would be the physiologically based approach. And if we try to defer a concept up from physiology, our settings would base on a theoretical concept and a derived strategy based on these considerations. And finally, nevertheless, we are interested in outcome. So if we do now the same approach for evidence-based medicine, then we would say evidence is finally given by results of large randomized controlled trials. The consequences is the settings based on improvements for predefined endpoints, whatever the endpoint of this large randomized controlled trial might have been. So then the next question is relevance. How important is an endpoint? So the defined endpoint of a trial for what? Short-term benefits, survival, quality of life. So be aware whenever we talk about evidence, we don't talk about a holistic approach to evidence in a general sense, but a randomized controlled trial looks for a primary endpoint and then for several secondary endpoints, but for well predefined endpoints. Though the conceptual consequence would be, if this is convincing, then we would like to have adherence to proven settings, proven by randomized controlled trials. So, and now if we mix evidence and relevance, how many sources of irritation influence the grade of evidence of a large randomized controlled trial, which is quite interesting to discuss. And we will have the chance during my talk to see and learn that on different issues. And then finally, which degree of collateral side effects or even sometimes damage are we ready to accept to get a higher probability for the endpoint observed in this randomized controlled trial? So finally, settings based on validated clinical data and a strategy that's derived from these validated clinical data. And nevertheless, at the very end, there's outcome. So if we accept that outcome is interesting for both rationales or approaches, then we would say physiology, whatever we measure is objective, it's measurable, it's an immediate effect where we are looking on. The benchmark for physiology is always normality. It's value-oriented, and it's very specific. So it's organ-specific, it's compliance-specific, it's resistance-specific, whatever. So and if you look at the evidence, it's subjective. So somebody is going to define, I think an hypothesis is going like this, and now I want to validate as a primary endpoint if survival increases if I reduce tidal volume or whatever. It's observable, but not in a direct sense measurable. It's more oriented on the long-term outcome. The benchmark is outcome. it's result-oriented, and it's holistic because it looks in the whole patient during the run of his disease. And now let's start off. So let's say this is the normal range of blood gas analysis. You are all very aware of that. So it's a pH value with its normal range. It's the PaCO2 and it's the PaO2, and that's what we accepted as normality or as the normal range. So physiology-derived targets of mechanical ventilation would, according to that, be to achieve normoxemia and normocapnia. So this was the primary approach, and we all learned that this primary approach to reach normoxemia and normocapnia was obviously not the wrong decision. And from Ted Colborne, there is a sentence, there is no RDS without a physician. And it's related to the fact that the primary goal of these physicians was physiology-based to reach normality, independent from the compliance or elastance, whatever you might use, of the lungs, and independent from the conditions from which the patient was suffering. So, and even now, if you go back to these ECMO trials, these first ECMO trials, there was a chance to get an adjunct to gas exchange via the native lungs, so to eliminate CO2 and to increase the PaO2 in the circulation while using an extracorporeal usage, which would have allowed to reduce invasiveness of mechanical ventilation, but they didn't do. They didn't do it because the goal was still to achieve normal physiologic values, which ended up that in both trials, the first trial, as you can see here, VT stayed the same, and there was the persistent development of barotrauma, and even years later, in 1994, when Alan Morris published his trial, the same was true. There was no change in peak inspiratory pressure and the persistent development of barotrauma, even while having the chance to add an extracorporeal device which might have allowed to reduce, at least in some aspects, the invasiveness of mechanical ventilation. So if we accept that normal values are probably not a good guidance for setting mechanical ventilation, do we then know what we would need? What would be an aim where we would try to get for? So I just give you these two. This is for 2 days ago. So maybe I go once back and you look only on the left side. It's a patient from our ICU. It's blood gas analysis, just took something out. So you see the PaCO2 is 60, PaO2 is 45. So would you say, well, that's sufficient? Would you say everything is fine, still in a normal range? It's unphysiologic for sure. So a high CO2, a quite acceptable pH. So, and then, then you see that and you say, well, that's obviously not from the patient with a PaO2 of 637. That's from the oxygenator, from the same patient, after having the blood, after having passed the oxygenator. And even there, we would say, well, what is under the conditions of the flow an acceptable value? So we don't know really where we are. So trying just simply to define what is hypoxemia. So maybe if you look carefully through the literature, if you look at the entrance criteria for large trials evaluating extracorporeal lung support, we might get close that we look for hypoxemia at values which are below 60. So it's about 40 millimeters of mercury. Below that, what we would accept as normal physiology. And is there an evidence for that? So of course, no. So literature suggests this greater 60, and we can be sure there will be never, ever a large randomized controlled trial looking for the threshold of hypoxemia. Because I think the disappearance rate of patients would be quite reasonable to figure this real threshold out. So the next question is, because we look at these things during the course of a disease, And this is a very interesting slide where somebody really looked carefully at what might happen in dependence from the time during which we develop hypoxemia. And it might be very acute without any chance of the human organism to get adapted and to show a physiologic reaction on a pathophysiology, hypoxemia, or if it's taking longer time, and finally, the degree of chances for adaptation make it probable if there is an acute hypoxemia on cellular level, or if it's simply a measured lower value that doesn't have any impact on cellular function. So normally we would look at this issue in a way that we say there is a degree of hypoxemia, so above 100, and then we enter the field of hypoxemia, and all of a sudden in this field of hypoxemia there is a threshold, but we are not really able to monitor the threshold. So only the long-term results might give us a hint this was too hypoxemic. So we know a little bit on ARDS patients from data from Ramona Hopkins, and we learned, well, neurophysiologic deficiency significantly correlate with the time and degree of desaturation in this study with a pulse oximetric desaturation below 90. We know also that if you look for a long-term outcome of patients who suffered from ARDS, and herewith I don't say that it's only hypoxemia dependent, but nevertheless hypoxemia played a role in these patients, that they have, even if you look at young patients, unsolved problems with neurologic function, even over a very long period of time, more than 5 years. We know that even some patients have changes which you can certainly detect in CT scanning, in this case just by chance, because these patients suffering from ARDS went into the CT scanner because of the question if they have neurologic dysfunctioning and if this is caused by a cerebral lesion. And there was a saying clinicians should be aware that they are at risk to develop brain atrophy. And that's something we are actually looking carefully in our department in Göttingen, and I can tell you that we have preliminary results and will hopefully be able to publish it at the end of the year. We are looking at specific weighing in the MRI, and this is from a high mountaineer who became hypoxemic. In the corpus callosum, there are considerable microbleedings after hypoxemia from high altitude, and this is an MRI from an ECMO patient. So, and you see in the same region, there is and very obvious, and if you talk to people who are very experienced and looking at these images, they say this is a very typical region where you normally get only microbleeds in consequence of hypoxemia. So now let's go to mechanical ventilation in a sense of CO2 elimination. So you all are aware of these basic physiological thinkings, and we are all aware that as larger as the dead space quotient becomes, as lower the amount of ventilated alveoli becomes, as worse it becomes, or more difficult it becomes to get rid of the CO2. And be aware, this is the same is true for CO2 as we were discussing before for hypoxemia. So it's not simply increasing CO2. So first of all, we have the supply. So this is body CO2 production. And body CO2 production normally doesn't change during ARDS. Why should it? But what is going to happen is that the alveolar ventilation, because of an increase of dead space ventilation, not anatomical, but functional dead space, is going to be reduced. So, and now it's again a question of time. So if there is a lot of time, then the human body can also use the storage rooms of bone, fat, and marrows and put some of the CO2 in these storages, still keeping the level in the blood on a constant level. But this takes time. And a short, acute increase of PaCO2 doesn't allow the body to follow these consequences and finally to be able to move CO2 in slower compartments. So what we normally expect in an ARDS patient is that we try by increasing the dead space, the minute ventilation, to get rid of the CO2. So there is a clear relationship between the minute ventilation and the increase in CO2. And of course, from a special range on, it's unphysiological minute ventilation that which we use to get rid of the CO2. Finally, we learn we are not successful in doing so. And we learned at the same time from some reasonable studies that the ratio of dead space ventilation is extremely closely correlated to the patient's mortality suffering from ARDS, which is an indirect marker or sign for the effect that there is a very small amount of finally areas in the lung that can be finally ventilated. So now we have, I go to this in a few seconds, we have learned maybe we accept, instead of increasing minute ventilation endlessly, higher PaCO2 levels. So there is a discussion, and I just go very fast through how high can CO2 be and what are the side effects of increased CO2. And I just give you some animal lab data. So this is a study from Lang, and he could show that there is an increase of injury if you use LPS model in a rat. If you have a hypercapnic rat, the George Laffey was able to demonstrate the absolute opposite. So he showed that it's attenuated. And this is also an experiment by another group showing that the increase of CO2 leads finally to the fact, in this experiment, the animals were breathing an increased amount of CO2 to modulate the innate immune reaction of the lung. So there was a down regulation of the immunocapabilities of the lung, which would make the lung more perceptual for any kind of infection. So, and it has also been proven later on by instilling then into the lungs endotoxin and showing that the reaction of the lung in these hypercapnic lungs was much greater than in the normocapnic lungs. And even perfusion in the microcirculation, this is, I'm sorry for that, it's difficult to read, but it's totally dependent from the partial CO2 pressure and cardiac output and the diameter of microvessels are depending from the PaCO2 level. So honestly spoken, we don't know what side effect we can expect. How can we really observe all these side effects? And is CO2 high a good or a bad guy? So I go quickly through now. So then we learned, okay, that there is two possibilities during changes that a patient is going to suffer during a disease. So one might influencing the chest wall elastance or compliance, the other one the lung compliance, and I go quickly through. So this has a dramatic impact on the effects of a given airway pressure. So a given airway pressure with a high or low lung compliance and a high or low chest wall compliance will lead to a totally different transpulmonary pressure. And what we learned is that the transpulmonary pressure is the driving force that is really transferred to the structure of the organ. And that's really the force that is going to cause stress. And we learned that stress is one of the factors that is going to kill the lungs. So just to get back in your mind, what are factors that increase chest wall elastance or compliance? So it's a disorder of the cage, pleural effusion, ascites, so there are many things, especially in an ICU patient, that might increase chest wall elastance and finally lead in the effect, this is very nice done work from Luciano's group some reasonable years ago, where they did a compartmentation of the elastance of the respiratory system at this time extrapulmonary and pulmonary ARDS. Those patients with pulmonary ARDS, of course, with a high lung elastance, and those with the extrapulmonary with a high chest wall elastance. And as you can see, if you look carefully, in those patients with a high chest wall elastance, there is, per definition, a much lower transpulmonary pressure because it's a nearly equilibrium between the elastance of the chest wall and the lungs. So we know also that in early ARDS patients and in healthy patients, there is a broad variation of the transpulmonary pressure, which is given by the same airway pressure. So we have to accept this is physiology also, and this physiology is existing in healthy as well as in sick patients. So the next thing we had to accept, it's not only stress, but it's also strain. And strain is finally defined by the amount of areas of the lung that can be ventilated in the ratio to non-ventilated area. Or in other words, the expiratory lung volume, which you can measure or determine in a lung to the ratio of the tidal volume. And this makes mechanical ventilation injurious or not. So the clinical equivalents are stress and strain, and again, strain is defined by the ratio of tidal volume to FRC. You have heard that for sure today. So I skip that. But again, as you can see, because it's linked by the specific elastance, you get nearly a straight line for healthy and RDS patients if you put VT FRC in relationship to the transpulmonary pressure, or if you combine, in other words, stress and strain in one slide. And what we have learned over time, and now back to physiology, that if you put strain to different animals and animal species, and your interest is to get a comparable severity of lung injury, it's time and, of course, strain dependent. And with strain, you can kill any animal dependent on time and the degree of strain that you are using. That's a lesson we learned from physiology. Well, interestingly, in a quite early time, so there was, at this time, the term ventilator-induced lung injury was really nearly not existing. It was 1900, as you can see, 94. Hickling published this data. So low mortality rate. So he did the other way around. He started with a clinical observational study. So he tried to create evidence, in our words. And in summary, he said, we believe that the results of this study suggest that the mortality was substantially lower, those with a higher PaCO2, caused by a reduction in tidal volume ventilation. That would be expected, and this was because of the design of the study from independent prognostic systems. So very early. At the same time, a very smart Italian guy, I assume that there was a good friend close to him that gave him the idea, Daniele Mascaroni, proof and the concept that this is not only true for mechanical ventilation, but also for spontaneous breathing. So stress and strain caused by spontaneous breathing causes very obviously the same effects as if affected by mechanical ventilation. Also very early, as you can see, 1998. So, as you can see later, Billy was then the result from all the conclusions that could be made from the effect that I've shown to you. And the logic consequence was the performance of a large trial. You are all aware of this trial. This is the American Network trial. You are aware of the data. And the intention was to show, no, it's not true. The intention was to show from the Americans that the Europeans are stupid and that it doesn't matter if you take 12 or 6 ml. But then they learned they are not totally crazy, the Europeans. And finally, it turned out it saved lives to reduce tidal volume. But anyway, at the same time, we observed something in a clinical study as well, showing that the days without extrapulmonary organ failure was also higher in those patients that received lower tidal volume, as an indicator that ventilator-induced lung injury is not only injurious for the lung, but also for remote organs outside the lung. And in this study, well, in the beginning, I was all the time laughing about it. And this is a slide that I took from a Tolmer study, because it becomes even more impressive. So you are aware, in this first study from the American Network, what they decided, they used a fixed table to adjust the PEEP level according to the FiO2 that was needed to reach a saturation between 88 and 98. This was true for the Tolmer trial as well as for the American Network trial. So this is a physiological thinking. I would like to achieve a fixed predefined value, and by doing so, I do a fixed, more or less fixed combination of values. This is physiological thinking, but not adapted to the actual physiologic status. And it becomes even more, let's say, interesting if you do that for the esophageal pressure, because the esophageal pressure is also dependent, again, from measured values and from things that you derive from physiology and that are not fixed by or fixable by a table. Anyway, so there has been a lot of debates, not about the effect of the low tidal volume ventilation, but about how small should small really be. And there, as you are aware, there has been a meta-analysis looking for this lung protective ventilation. I don't go into details, just if you allow me one short comment. So I show you 2 in total, meta-analysis, and you should be aware a meta-analysis is not usable to increase evidence. A meta-analysis was originally designed to create a smart hypothesis based on some values, but not to increase evidence. So, something that we observed from trials becomes not more evident if we pack it together in a meta-analysis. So, but nevertheless, this has been done, and as you've been aware, obviously, low tidal volume ventilation decreases the amount of patients that develop during mechanical ventilation acute lung injury and deeper or severer degrees of ARDS. But obviously, once somebody has developed an ARDS, it has no impact on mortality. Maybe one of the reasons might be that even using small tidal volume, there is still, that's an effect that has been observed in this study, there is still 1/3 of the patients that are hyperinflated even while using high tidal volumes at inspiration, but also at expiration, indicating that for those patients, protective ventilation, according to the American Network trial, was not protective enough. I don't say it was not protective, but probably not protective enough. Let's go very fast to PEEP. So, you know, there are, let's say, with the exception of the American trial, which I mentioned shortly later on, 2 large trials, the LOVE trial and the EXPRESS trial. Both trials, to make a long story short, showed no difference, but both trials showed that in very hypoxemic patients, there is obviously a doubling of the mortality if in these patients low PEEP levels have been used. And it was indicated in the LOVE study, but by a higher number of patients with severe hypoxemia, and in the trial from the EXPRESS, it was indicated by any adjunctive therapy that was needed to avoid hypoxemia. And in this trial, there was the first hint, not a proof, a first hint that using high PEEP levels might be even for those patients that are suffering from ALI, might be even worse or might be even decreased survival. So then we became aware of this again, meta-analysis. You learned, and the meta-analysis showed a tendency again and proved that obviously so patients with ARDS have a profit from higher PEEP levels, whereas patients without ARDS clearly showed a tendency even to have a worse outcome than those patients with a higher level. And in summary, that's it. Our results further that such a benefit is unlikely in patients who are not suffering from severe disease. So the question was then, and this is work where I had the honor to work together with Luciano, was has this something to do with recruitment? So first of all, there had to be defined, is there a threshold? Can we define a threshold where we say below or above that, we call these patients by a step from 5 to 45 centimeters of water recruiters or non-recruiters? And do they behave different? That's something what we learned. They behave even in mortality different. And those patients having a high potential for recruitment, the mortality is much higher. And then the speculation was, well, maybe this has something to do with the superimposed pressure. You are aware of the superimposed pressure. It's given by the edema fluid in the lungs. So, and if you put slices into the lungs, so you expect that with an increase of the gravity of the lungs by the increase of the edema, the pressure on the last alveoli close to the vertebra is increasing. Imagine in extreme, the thorax is totally filled with water. Then you have the centimeters of water as a pressure close to the vertebra as the height of the thorax is. So it's quite explainable. And the idea in this work we finished that Luciano was able to publish with data that have been gathered in Milan and in Göttingen was that we finally were able to show, well, unfortunately, this is absolutely not related to recruitment. So the recruitment is not a predictor for the PEEP level that is going to change anything in these patients. Or, in other words, the idea was to derive a so-called CT-derived PEEP. And the CT-derived PEEP was set together from the superimposed pressure and the power you need to overcome the resistance of the thoracic cage and the lungs. And it finally ended up in the things that we had to learn. As you can see, the CT-derived PEEP as a mixture of the forces to overcome the resistors of ventilation is not related to the recruitability of the lungs. So I don't go into the details. So at the very end, we have again, by a clinical study, but not by a randomized controlled trial, learned a lot, many open questions. We found out, if I am allowed to go back, that there is a quite reasonable PEEP for a large population of patients independent from the severity of the ARDS, where the PEEP level is around 60 and might make sense in a sense of CT-derived PEEP, but then we learned this is not related to recruitability. You have seen this slide already, so I'm going close to the end of my talk. So this slide is what is actually given and what we were discussing. I think we all accept that we would probably use still higher PEEP, maybe 16 or around that. In patients that have severe to moderate ARDS, we become, if we try to draw the conclusions of what has been said and found, a lower or moderate PEEP level in patients that have mild ARDS or stay even very careful with it, and that we have a quite reasonable, as Alain showed, amount of options where we still do not know what the value of this option is at the very end. And that's what Alain also said. Interestingly, these two interventions are meanwhile used for everyone and through everybody without any rationale. At least I do not see a rationale for it. But anyway, it's something that we observe. And it has obviously, at least in my country, something to do with reimbursement, but not with medicine. So what do we actually know? So we know very probably we should avoid volute trauma and atellect trauma. We can reach that by reduced tidal volumes. How much we should reduce tidal volumes, if we should stay ultra-protective, adequate pedal, and, it should read for, and identification, at least for the potential for recruitment. And we have learned that we should accept permissive hypercapnia, however, in a range we actually not really know, and that the PaO2 of greater than 60 seems, at our actual knowledge, to be wise. This should reduce biotrauma, but the final and most important conclusion, the transpulmonary pressures generated and the ratio of tidal volume applied to aerated lung areas determine, whatever we do, the extent of biomechanical stress for the lungs. This is a stressor. And everything, and that's physiological thinking, that increases that and that we are able to decrease might help out in not further increasing the injury to the lungs. So my summary is, physiology explains how things are or should be. It delivers an explanation for what might happen if things are not like they should be, out of range. It delivers the rationale for an approach or a setting. That's something we can consider. And it helps understanding, explaining, and it's hypothesis generating. So, and the evidence, based on testing of an hypothesis in the clinical setting, it delivers the proof for outcome relevance of a setting. Doesn't say that the outcome that we are looking for makes any sense. Let's say 14-day mortality. I'm not interested to survive the first 14 days. I'm interested to survive. So, but if this is the end point, I don't know. Anyway, so testing, validating, and confirming or rejecting what we get tested in the style. And that's my final sense, as for the most evident mechanical ventilating settings, evidence is missing. We even have no evidence that mechanical ventilation per se is effective. Physiologic knowledge and understanding is the only available background for most settings we are using. Evidence for these settings might prove the physiologic rationale behind is relevant for outcome. Thank you very much.